Welcome back to Postgrad. I'm Zach Hodges, a pediatric intensivist from the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
So we have a great topic today. It's all things acid-base. And to do that, we have Dr. Bill Bortcosh joining us again on the show. Bill received his MD from Albany Medical School in New York, followed by pediatric residency at the University of Massachusetts, followed by critical care fellowship at Mass General.
Yes. You might remember Bill Bortcosh from his 2 early Postgrad episodes, Work of Breathing Physiology and Ventilation of the Neuromuscular Patient, and we are so excited to have him back. Part 1 of this series is really all things metabolic acidosis. What do you do with the gap? What's your differential? And how are you going deeper into what's going on with your patient?
Yes, it's a topic that you'll apply every day in the pediatric ICU. It's relevant for our newest trainees and even those who are getting ready for their board exam coming up very soon.
Let's get right to the content. Thanks for listening to Postgrad. We are so excited to get back to the basics and talk about acid base. Here with Dr. Bill Bortcosh. Bill, thank you for joining us today. What's new with you since our last recording?
Oh, thanks, Alice and Zach. I'm super excited to be here. Since our last recording, I transitioned from my work as an intensivist to an associate medical director of safety at a pharmaceutical company. I've been enjoying it. It's a transition I didn't make lightly, of course, but it's been a nice way where I've been able to pursue my academic interests as well as like my interest to help people with sort of a work-life balance that made more sense for me. And I'm still able to moonlight clinically, 1 or 2 times a month. So that's been fun too.
Yeah, that's so interesting hearing about the transition in your career. Would you tell us more about maybe how that seemed right for you and what is like a day in the life like as a physician working for a pharmaceutical company?
Yeah, I mean, it's a little bit of a loaded topic. I could probably do a whole podcast on physician wellness, but honestly, it was seeming that like the clinical responsibilities took precedence and trying to do things additionally that were more my passion, such as teaching, education, clinical research with patients. I was doing like simulation teaching with patient families, which I was finding very fun and interesting. All of that was not time that was bought down for me. It was time that I was having to do on my own kind of time. And I was finding that I was getting kind of physically and emotionally exhausted. And so I looked for ways to transition to my career to where I could take my skill set into something that would still be useful, still help people. And I was very fortunate to find a job at Vertex Pharmaceuticals. And it's been great. I mean, as a medical director of safety, so like on the labels of meds where you like have literally like everything that could possibly happen to a human is listed. That's kind of been our yeah. Nausea, hair loss, spontaneous combustion. Yeah, all those can happen with our drug, but probably won't. No, that's essentially like a medical director of safety's job. You work with the drugs pre and post marketing. With clinical trials, you help kind of parse apart the information to figure out what's a real risk and what's not a real risk. And you work closely with regulatory agencies to kind of make sure that whatever's going to go on the investigator brochure or the label post marketing is kind of in line with like what your study findings were. It's been a really interesting role. It definitely requires someone who's like had a little bit of like boots on the ground to do it. But there's people from all walks, and corporate culture is very different than hospital culture.
Yeah, I really appreciate you sharing your story. And I think you're an intensivist who love taking care of patients and teaching and many other roles. And it's so hard to find that balance. And maybe one take home from our conversation already is that we have to continue to optimize systems to empower physicians to do everything that's so important, whether it be taking care of patients, educating, research projects. And it's just so hard to do that so well.
It is, and I think that naturally as physicians, a lot of people are drawn to this career because they want to help others. But the problem with that is that we're human, and to help others, oftentimes we have to give from ourselves. And if you kind of keep giving and giving and giving, at the end of the day, you you start to feel that you don't have much left to give, and it's something that I truly hope that most people won't have to encounter. But when you're finding that you're feeling exhausted with the idea of, taking care of a dying family, when someone's tragedy becomes your burden, maybe it's time to start thinking or self-reflecting about why you feel that way.
Yes.
Oh,
very fair.
It's very powerful. Well, another hot topic in critical care, acid-base physiology. How did you become interested in this topic? I mean, how could a person not become interested in this topic?
How could a person not become interested? Oh my gosh, yeah. I mean, every time I say acid-based when I'm teaching, people tend to roll their eyes. But I'll tell you, I remember exactly when it happened. I was a fellow, and we were caring for this renal transplant patient. And this patient had gotten 10 or 12 liters of fluid in the OR. You walk in the room. She looks like that Willy Wonka kid, the blueberry one. She's on BiPAP, still high settings, still satting high 80s, low 90s. And I'm trying to diurese her. And the surgeon walks in the room. He's like, her bicarb's 28. She's dry. You can't diurese her. I'm like, bro, look at her. What are you talking about? And I gave him articles. I was showing. He was like, no, bicarb's high, contraction alkalosis. She's dry. I'm like, and then I basically did this beautiful mind montage over the next several days where I
reviewing every piece of literature on the topic.
Every piece of literature that was relevant to this, and why am I right? And I found a narrative, or at least I learned a lot, and I found an explanation. And a lot of people have had similar questions that I did, as is contraction alkalosis real? What does it mean to have a high bicarb? What does it mean to have a low bicarb? And how do you contextualize this? And I feel like it just kind of helped me as a clinician to sort of improve.
That's so fun. And I think we're going to be doing a little bit of myth busting today on this acid-base episode.
Let's do it.
Yeah. So excited to get to our case and talk about good old acid-base. I feel like we should go ahead and put a plug here. Not sponsored by Vertex Pharmaceuticals, and that we really appreciate you sharing your time with us today.
Yeah.
Any conflicts of interest at all?
No, not this. I'm doing purely for enjoyment and teaching.
Fantastic. How about I give you a case and then we can get started?
Yeah,
sound good?
Let's do it.
So you're working overnight in the PICU. You have a 16-year-old female. She's brought in by EMS. She was found down at home. Transport team intubated her because she was obtunded, not protecting her airway. No history. Heart rate's a little high in the 90s. Otherwise, her vital signs are within normal limits. You order some screening labs. I can give you that chemistry here. Generally looks okay. I mean, the residents here presenting it to you. Sodium 140 is fine. K of 3.8, it's fine. Chloride of 100. Bicarb suspiciously a little bit low at 20. BUN 18, creatinine 0.8, and a glucose of 120. So what are your initial thoughts when thinking about this patient, looking at this chemistry? Where do we go from here?
So I have to tell you that I saw a very similar patient to this in residency, and I made the diagnosis off a very similar chemistry just like this. So I'm hoping that our listeners will be able to do it too. But looking at that, it looks normal, right? Everything is kind of within laboratory range, but I feel like we have to take a closer look at this. So let's kind of step back. Zach, you had mentioned that the bicarb is low. Why do you care?
When you're in doubt in the ICU, you make everything euboxemic until the patient gets better, right?
Yeah, that's right. This is out of range. Just give some more mag.
No. I'm looking at that gas and the bicarb as a new attending, and I'm yelling, "We need a gas! Somebody tell me the pH of this patient's blood right now."
Yeah. Interestingly, I like pH, but I don't use it too much for acid-base purposes. I use it kind of a rough screening. And the reason is because I find that mixed disturbances can really be trick you into not widening your differential. So when I look at a BMP, I kind of remind myself, I take a step back and I think about, why do I care? Or why is acidosis important to me? And for me anyway, there's two reasons why I care about acidosis. Firstly and foremost, acidosis can straight up kill you. So that's important to think about, right? Like if your pH gets low enough, you die. So think about like your obtunded pneumonia, like your 6-9 pneumonia or something. Like that person, like they have a pure respiratory acidosis, but like they're not thinking right. They don't look right? It's not that they've infarcted their brain necessarily, or at least I hope not. But acidosis at a certain point can cause protein denaturation, and like a neuro exam is like a quick way to just kind of with your eyeballs see that that's caused protein and enzyme denaturation, like things are not communicating the way they should be. Maybe you guys have worked in the cardiac ICU, I know you have, and you had this person maybe on 3 or 4 pressors, and all of a sudden they got a mucus plug and their blood pressure dropped. I'm not sure if you've seen that before. So
Certainly.
Definitely, I feel like that happens like every day in the CI. But so this is an example of like how acidosis can affect blood pressure, because there are receptors in the blood vessels that help with autoregulation. So autoregulation, if you may or may not remember, is like if you were to cut out an arteriole out of someone, the arteriole could constrict or dilate based on what's flowing through it, how much volume and what kinds of electrolytes or stuff. If you have too much acidosis, it basically just becomes a stiff tube, so you can't really maintain your blood pressure well. And also the receptors that receive epinephrine and norepinephrine, those are also affected by acidosis, and those can denature. So if they're less responsive, you don't get that nice squeeze that you would need to like kind of maintain blood pressure, so they can drop your blood pressure as well. And of course, we think about electrolyte disturbances. So all that together can kind of put your life in danger if your pH gets too low. So for that reason, that's one reason why acid base is important. Like acidosis can kill you, and we should probably try to figure out why it's doing that and prevent it. And the second reason for me is probably the more common reason, or the more practical reason, which is that acid base can generate a really great differential diagnosis, and then that can inform your diagnostic and management plan. And again, to be a good doctor, I was always taught you need at least 3 things on your differential.
That's right.
It's beautiful. Yeah.
So
So we want to be good doctors. We need at least 3 things. I'm looking at this patient. How are we going to get there?
Yeah. All right. I love it. So when generating a differential, this is the part that it sounds boring, but I actually think this is like probably the most interesting part, is like thinking about your differential diagnosis for an acid-base disorder. So in acid-base, there are only 5 things it can be. Each thing has subcategories, of course, but the 5 things in acid-base that we all know are 1, anion gap metabolic acidosis, 2, non-anion gap metabolic acidosis, 3, metabolic alkalosis, 4, respiratory acidosis, and 5, respiratory alkalosis. It's one of those 5 things or a combination thereof. And I know it sounds boring. I know like, I don't want to go through this list, but I think that what makes it fun for me is that very rarely have we talked about why these things are. And when we think about the why, it really like informs what we're doing and why we're doing it. So that's what I think is fun.
Yeah, that sounds great. And I feel like the anion gap acidosis is probably the one that gives us most of the confusion. So do you want to get started there?
Yeah, and probably most of the serious pathology too. I mean, as you guys probably have learned as like attendings, like most of your job is not necessarily to find the diagnosis, but just to make sure it's not the dangerous ones. Mm-hmm. And once you get past the not dangerous ones, the rest will sort of shake itself out over time. But yeah, let's jump into anion gap metabolic acidosis. So one thing in like fellowship that I didn't quite realize like what it meant to have an increased anion gap, and it took me a little bit of time. So like starting foundationally from like what an anion gap is. So you guys may remember you have like some positive, like just in the universe, you have positive things and negative things, and they kind of like bind together to make sure everything is like neutral pretty much all of the time. In your bloodstream or in the serum or in your body in the cells, you have positive ions and you have negative ions, cations and anions. So the positive ions is mostly sodium. There's a few others like calcium, mag, potassium, etc. But like for the purposes of generating a differential diagnosis that is like commonly agreed upon by the medical community, let's just say sodium is the positive ion. Okay. And then as far as anions, the 2 ones that are most in abundance are bicarbonate and chloride. And typically your sodium is about 140, your bicarbonate's about 24, 25-ish, and your chloride's about 100, 105, 104. So, that will leave you with an anion gap of usually about 12. So what does it mean when an anion gap increases? So like, why do we care? Again, I'm going to say the words Lewis acid, try not to glaze over, but do you guys remember like Lewis acids from chemistry?
Something about donating protons and accepting. Yeah.
Mm-hmm.
So the Lewis acid is like a positive ion that accepts electrons. So it's a positive thing. So when your anion gap increases, you're saying that there's more negative ions in your blood. But remember, those negative ions can't just come out of nowhere. If there's more negative ions, there has to be another positive thing. So, or more positive ions added, or an unmeasured positive ion. So that unmeasured ion is something that's been added to the system, or in other words, it's an acid. An acid has been added to the system because it's an anion gap metabolic acidosis. So your job then is to figure out what is that acid. And once you find out what that acid is, you could probably fix your patient, or at the very least get them on the right track.
So maybe to restate that, when we start seeing an elevated anion gap, we're inferring that there's more negatively charged particles in the blood, but there has to be positively charged particles, that being the protons, the acidosis, that's driving this gap. Okay.
Yep, that's exactly right. Yep. And I think just realizing that there's an acid behind every anion gap differential is kind of leads you to figure out not only what's going on, but like how do we address it. So do you guys remember the differential for anion gap metabolic acidosis?
So many different mnemonics.
So
the
many
anion
ones.
gap one is mud piles.
Oh my gosh. Yeah, I feel like in 2024, like I am considered old school and you guys are probably the new ones. Like if you told me there was like some weird new acronym, I would believe you. But I feel like it's always been mud piles, you know. So why don't we use mud piles as an example to go through this, and then for each one, we'll try to name an acid. And just to give you an idea of like the acids that are behind anion gap metabolic acidoses, if that sounds okay.
Yeah, let's do it.
Oh, yeah.
All right. So methanol, the first one on mud piles. So that's an alcohol. Alcohols, they generate specifically formic acids, ketones. Methanol does it in a very specific way where it consumes intermediaries along the Krebs cycle. So it doesn't allow you to go through the whole Krebs cycle and generate ATP, and you get this buildup of formic acid, which is really interesting just by interrupting the Krebs cycle. So we do this all the time. And in addition, you get some ketones because methanol, as well as some other alcohols, can basically create more aldehydes and keto acids because they don't allow formation of pyruvate. And the ketones on the side can give you a fruity breath. So you may or may not have noticed maybe after a vigorous college night that your breath was like a little bit fruitier for like the whatever you were drinking previously. And that probably had something to do with some ketones. So
methanol equals formic acidosis.
Formic acid, yep, exactly. And probably among others, but like that's one of the ones that's well described in the literature. What about you in mud piles, uremia?
I feel like this one's really confusing, right? Because there's no uremic, there's no acid that I think of with uremia. Yeah,
if you were to actually test ureas like PK, pH, it would probably be in like the high 7s, 7.5, something like that. And you've seen those guys on Survivor, right? Like they drink their pee like all the time. And like nothing happens.
It's not the BUN, that's the acid in uremia.
Right. So I challenge you and any of the listeners to look at the anion gap of anyone whose GFR is fallen somewhere below 15, like all your kidney failure patients. And I guarantee you're going to find a high anion gap and probably a low bicarb in most of those patients. And the reason is because when you fall below a specific GFR, the number I've seen quoted is about 15 mLs per minute, you begin to retain non-organic acids, sulfites, phosphites, things without carbon. And those things are things we just don't measure in the bloodstream that often. And my hypothesis anyway, and there are others who share this hypothesis, is that the true culprit behind like uremic pericarditis, uremic encephalitis, all those urea like disorders is probably these non-organic acids or something else that's not being filtered out by the kidney or an accumulation of them. So I think that's.
Oh yeah.
So uremia, not necessarily like a acidosis like we think about with lactate or formic acid even, but it's more like a buildup of all these other metabolites.
Yeah, exactly. Which are acids, technically speaking, right? So DKA, diabetic ketoacidosis. I mean, it's in the name, right? Though we have to remember with DKA, you get actually like basically two kinds of acid. One is from the dehydration and poor perfusion. You're going to get a little bit of a lactic acidosis, of course. And then just from inability to absorb glucose, into the cells, you're going to get a buildup of ketones because you're not going to be able to use oxygen and stuff to break it down. So ketoacidosis and lactic acidosis for diabetic ketoacidosis. And then we can kind of like bang through the rest of these too quickly. I don't want to like drag too much, but the point is that there's like an acid for each one. So paracetamol, which is British Tylenol, but just depleting glutathione, which we all know like happens, and people have to go on N-acetylcysteine. The depletion of glutathione causes an acid called pyroglutamic acid to build up. So that's just one that can happen. Like, again, look at your Tylenol ingestions, check that anion gap. I bet you're going to see it. I bet you'll find it.
Yeah. And this pee in mud piles is important because there are some situations where you just always send a Tylenol level, right? And it's important to link that to your anion gap metabolic acidosis.
Oh my gosh. Sometimes, like you're in a place where your lab's just not working, right? And if you have someone whose mental status is a little bit weird and they have an anion gap, like you got to start thinking, right? So like, for example, like say like they have an anion gap and they're kind of obtunded. What's a quick way, like, or a cheaper test that you could use to diagnose like an alcohol intoxication? You guys know?
Osmolar gap? Is that what you're going after?
Yeah. Osmolar gap. So again, osmoles, like similar to an anion gap, you should have a gap of about 10 usually, which is the serum osmoles minus the measured osmoles. Measures like 2 times the sodium plus BUN over 2.8 plus glucose over 14, something like that. But anyway, I think I'm close. Yes. And if you do that, you should have a gap that's about 10. And if it's higher than that, there's an unmeasured osmole in there, and usually that's an alcohol. So that's a quick way to do it. And then also, if you are finding like a person who's obtunded at home and there weren't really a lot of medications around, they have an anion gap, and you're not able to measure Tylenol level right away, well, Tylenol can be high on your list. That's a combination of the story and the chemistry kind of coming together to really narrow down your differential.
Yes. Because this serum osmolality just seems to find its way onto high stakes exams, I might just clarify that equation here. So your serum osmol, 2 times your sodium.
Yep.
Plus glucose divided by 18.
18, thank you.
Plus BUN divided by 2.8.
Yes, thank you. Yes, thank you.
Just a word.
No, I appreciate you doing that. Yeah. I'm like, oh no, is it 14? Was it something else? Yeah, glucose over 18. That's good. Thank you.
Yes. Where were we? Where were we on our mud pile list?
So we did the P. There's a couple other Ps, but I would recommend just checking the attached document if you're curious about fenformin and peraldehyde, which we don't check out too often. Iron is the I. That one actually is a bit of a mystery. So iron, a lot of people have said that like the acidosis comes from the resulting like heart failure, liver failure kind of stuff, and like sort of like lactic acid buildup and just volume depletion, but or I should say circulating volume depletion. But some people also think that there's maybe like unidentified hidden acid, something that complexes with enzymes that has yet to be identified. That being said, a large anion gap metabolic acidosis is something that's commonly associated with iron toxicity and definitely something to track. Iron toxicity is its own thing, and we could go off on that for a while.
Terrible. But it's not just I for iron in mud piles. It's also
Yeah, there's others. So isoniazid is a common one. We actually had a medical student in our residency, when I was in residency, who there was a kid who was seizing in the ED, and the medical student saw the anion gap and went through his mud piles, and he was like, I know it's not any of the others. The lactate is negative. There's no osmolar gap. The tox is negative. He's a kid. He probably doesn't have DKA. So he's like, I think it has to be isoniazid. And they gave an antidote, which was vitamin B6, and the kid stopped seizing. It was really like amazing.
Wow.
Yeah, it's just from the chemistry alone, like created a differential, like really brilliant. A kid with like not too much experience and just was able to kind of like save the day, like which I think is just really cool thing to do from a chemistry, And isoniazid causes B6 depletion, which can lead to a lactic acidosis. And by giving B6, you can basically reverse the whole thing.
Interesting. Wow.
Yeah. And of course, in babies, we always have to, when we see an anion gap in a baby, we always have to think about inborn errors, organic acidemias, urea cycle disorders, stuff like that. And that's going to lead you down a whole crazy diagnostic path. I recommend getting metabolic or endocrine involved because it's a lot.
All right, so next up is L, lactic acidosis, our favorite in the pediatric ICU. What do we need to know about lactic acidosis?
Well, I'd say that it's kind of like sepsis. If you see a fever, it's like sepsis, and like a kind of a sick appearing kid. If you see an anion gap, it's going to be the first top 3 things is going to be lactic acidosis. Because lactic acidosis in and of itself implies one of the 3 things that we kind of like fear in the ICU, which is like circulatory failure, cardiac failure, or volume depletion, which like are essentially shock states. So once you rule those out, again, our job in the ICU oftentimes is to just take out the dangerous stuff. Then you can kind of start going your more like luxurious differential of like, ooh, is this an inborn error, kind of stuff. But so lactic acidosis should be probably top of your differential. But the nice thing about lactic acidosis is it's often accompanied by a supporting exam. So like I'd say like the most important thing that no one knew how to teach me as a resident or as a fellow, and you just kind of had to learn it on your own, was sick versus not sick, like the eyeball exam. Over time I came to believe that my stethoscope is a piece of garbage. And I was just like, rather than trust my ears, like really the priority was given to my eyes and my experience. And I'm like, that kid looks good, that kid doesn't look good. And very rarely have I been mistaken, since I kind of figured out the patterns. So it's just a skill that kind of comes with time and certainly not something that's easy to teach over a podcast.
Oh, sure. Maybe one thing to add for our trainees, you need to be aware of the difference between a type A and type B lactic acidosis, with type A due to shock, hyperperfusion, and then type B usually due to either endogenous catecholamines or the catecholamines we provide them. Think about that asthmatic who's on lots of albuterol and terbutaline having a lactic acidosis. Of course, you can have shock and hyperperfusion in that setting, but a type B lactic acidosis is much more common.
Yes, and seeing that in the CI is something that's very common too. You'll get into a debate here about whether you should be a checker or not a checker when it comes to that kind of stuff. There are people who see that lactic acidosis and they'll start checking at Q2 or something like that. And, everyone's going to have their opinions on that. And maybe it's a discussion for a different time.
Yeah. Need to pair that with your sick or not sick physical exam.
Yes. Yes, indeed. So let's bang out these last two anion gap mud piles things. So something that I'd say most young folk in America have familiarity with, which is ethanol, less familiarity with ethylene glycol, which is antifreeze. So again, these are alcohols, so they will consume Krebs cycle intermediaries and cause buildup of organic acids, similar to what methanol does with the formic acid. And we kind of touched on osmolar gaps, quick way to screen for that when you think your like turnaround time for your ethylene glycol level, your ethanol level is going to take too long. Usually ethanol is quick turnaround, but for the other weirder alcohols, it can take a lot longer. So highly recommend looking to osmolar gaps.
I want to ask one clarifying question. Do you have like a set range that you have for an anion gap? And then do you ever change that set range based on other labs or not necessarily?
So I do have a set range. And I referred to the article by Carmody. I think he was a British intensivist, or maybe not even this, but anyway, he wrote this awesome article. And when you look at big populations, the anion gap range for normal is somewhere between 8 and 12. And giving people the benefit of the doubt, we use 12. What Zach's referring to is that there's other anions that can kind of like shift what your average anion gap should be. So for example, albumin is probably the biggest contributor. So I don't like to do this typically because the way I think about acid base is in the sense of a normal curve. I like to think about what's in a normal curve and like what's outside that range. And then if we're still finding problems, we can kind of re-examine the albumin later. But so a mean anion gap, looking at these large populations, is 12. Basically, and it could be 8 to 12, but let's say 12 just to give them the benefit of the doubt. Like, if we use 8, our sensitivity is going to go up, our specificity is going to go down.
Yes.
And then the mean for the standard deviation for an anion gap is basically like plus or minus 2. This is why I was saying to Alice, like, you don't really need a pH, because if you have an anion gap, you're walking in and you see this chemistry and you see an anion gap of say 20, that's 8 above 12, or in other words, 4 2s or 4 standard deviations above the mean. And if you think about your normal curve, without even seeing a pH, that's like a 99.9, add a few more nines, like percent, that this person has an anion gap metabolic acidosis. One of the mud piles is causing this issue, and it's basically your job to figure out which one. So I think that's cool.
Oh, yes, for sure. And I think early on in critical illness, I don't think we need to even be worried about correcting for the albumin level to diagnose an acid base status. Maybe in the occasional long stay patient in the ICU who have been hyperinflammatory, the albumin is 1.9 or something. Maybe it shifts things a little bit. For those maybe who want to read more about it, there's some literature out there that the anion gap can be estimated when you multiply the albumin level in milligrams per deciliter times 2.5. So the more albumin you have along,
that's clever.
The more of an anion gap you should have available in a normal stance.
I find that's clever. It's like a nice way to play around with the equations and sort of like a different perspective. And I think different perspectives are just really good ways to like look, because sometimes you can see things that you just didn't kind of realize before, just kind of taking a glance at it.
Zach, wait, to restate that. So if your albumin is 4 and you multiply that by 2.5, you get an expected anion gap of 10.
Yeah, which is right in the middle of 8 and 12.
Nice. And if your albumin is 2 and you multiply that by 2.5, you're expecting that patient to have an anion gap of 5.
Thereabouts, yeah. I mean, there are other aspects of the anion gap, but yes, in general.
So there was this fascinating case report I read kind of when I was prepping for this about someone who had a negative anion gap, which we're not going to go into too much in this, but they had a negative anion gap of negative 47. Which is like, what? I'm glad that someone got this published, but basically this was like a very sick patient with like a lot of capillary leak, and in addition to like anions that were lost, they basically had a very low albumin. So a negative anion gap they're basically saying can be attributed to like loss of albumin as well as other anions, and thinking about like what those are and where you're losing them from. It's something that's rare and paid less attention to. Just think pathology is fascinating.
Very interesting.
Yeah.
This was our first real good tangent on acid base, which there are going to be many more of these. Do we have any more?
Yeah, you almost got me on capillary leak. I was like, like squirrel.
That's right. Did we cover all of our mud piles before we move along?
So there's one more.
There might be one left.
Yeah, I think there's one more.
We led to a mud pile. What's the right. S?
So the last one we got, classic, is salicylates. Aspirin is the common one in the United States. Basically, salicylates cause an anion gap. It's well known. Disrupts the Krebs cycle, decouples mitochondria. You're getting an accumulation of organic acid intermediaries and lactic acidosis. As part of that. But salicylates have another very interesting idiosyncrasy to them with their sort of pathogenesis and like physiological presentation. Do you guys remember what that is? In addition to an anion gap metabolic acidosis, you have one other thing that goes with salicylates.
They're stimulating the respiratory centers a little bit, aren't they?
Yes. So they're directly toxic to like the pons area, and they're causing some hyperventilation, which results in a respiratory alkalosis. And you can actually test for both of those, and we're going to get into that. But kind of summarizing anion gap metabolic acidosis before we jump into it, it's probably the most difficult one to conceptualize, kind of as Zach had mentioned earlier. But the idea is that we've added an acid to the system, and it's our job to figure out which acid, and that's where your differential diagnosis comes in. And each one can have an antidote, right? Lactic acidosis, fix the perfusion state. That's the problem. Isoniazid, give B6. Alcohols, just hydrate in time, and if there's an antidote, give it. But usually they have to wait.
Yes.
Yeah.
Maybe for the listeners, one more aside. We think about mud piles as being the most common mnemonic here for anion gap acidosis. If you wanted a separate one to think about, metabolic acidosis, anion gap metabolic acidosis, they can kill you. KILU. So ketones for K, I ingestions and all the number of ingestions we've mentioned, L for lactate, and then U for uremia. So
that's a good one.
Yeah, I like it.
Just kind of condenses all the different ingestions into one. Which you got to bring out Google and do all that again. And thank you for listening to this episode of Postgrad. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.